My name is Evelien Dekker from the Amsterdam University Medical Centers in Amsterdam. And I'm happy to join you in this Düsseldorf symposium. The topic of my talk today is on serrated colorectal lesions, and I was asked to discuss the clinical relevance and the endoscopic approach. Serrated polyps are actually of different types. So we have the traditional serrated adenoma on the upper side of the slide, which is a relatively rare type of polyp, and it looks almost like a villus polyp. However, when you look into more detail in the histopathology, it has clearly some distinctions. At the lower end, you see the hyperplastic polyps, the ones that we know for longest, usually small and innocuous, often in the left side and the rectosigmoid of the colon, and they appear to have no risk. However, the middle group is the most complicated one, especially because of the different names those polyps have. At the moment, we call those lesions sessile serrated lesions. However, in the past, they've had several other names like sessile serrated polyps, sessile serrated adenomas, or adenoma/polyps, many different names. And that is also why there was a lot of debate and confusion in literature because of the still evolving terminology. And that's why I, at the moment, prefer sessile serrated lesions, because these lesions are no adenomas and they are not the overall group of serrated polyps. What we know now is that those polyps can slowly develop into cancer. So apart from the well-known adenoma carcinoma pathway, there's also the serrated neoplasia pathway, which is a pathway where amongst others, BRAF and mutations and SIMP, which is hypermethylation, a sessile serrated lesion develops, and then it acquires more mutations, running into a lesion with dysplasia, and in the end resulting in a carcinoma. So again, the carcinomas develop from those lesions, sessile serrated lesions that are dysplastic. And those lesions are actually relatively rare, those dysplastic sessile serrated lesions. And that's why it is thought that they must be a very short interval between a non-dysplastic sessile serrated lesions and the cancer. And it's mainly from epidemiology data that our colleagues from Australia have concluded that indeed there must be a very long dwell time for sessile serrated lesions, but very rapid progression once the lesion acquires dysplasia to cancer. So indeed, sessile serrated lesions might still be small and already have a dysplastic part in them. And this is a very nice example of such a very small focus of dysplasia, which is really a sign, as you understand, of advanced neoplasia. And this is another example of the histopathology of a very small T1 adenocarcinoma situated within a sessile serrated lesion. I think quite clearly showing with some circumstantial evidence that those lesions indeed are of risk to develop into cancer. So how about our detection rate for sessile serrated lesions? Well, the problem is they vary widely. We are already very well known with the varying adenoma detection rates of one endoscopist versus the other, but the same accounts and maybe even more for sessile serrated lesions. You can see here in a US clinic, actually the clinic of Dr. Rex, the varying adenoma detection rates here, varying from 47% of patients, of doctors detecting at least one adenoma in their patients, and here as low as 17%. When you look to the right and we look at the proximal serrated polyp detection rate, you can see the same endoscopist also was the best in detecting serrated polyps on the proximal side of the colon, whereas the one with the lowest ADR indeed had a remarkably low detection rate of serrated polyps. However, we also know now from more literature that it not always comes as one-to-one as in this case. But what we do know for sure is that detection rates for serrated polyps vary widely between endoscopists. Why? Well, probably most of all because the serrated polyps are not so easy to detect. They don't have a very bright color like most adenomas, or very light like the hyperplastic polyps, but often their color is the same as the surrounding tissue. They often have some mucoid tissue or some features adhered, so you might be misled. And they are really quite difficult to detect, as you can see here. A recent American study showed us that the sessile serrated lesion detection rates were high if there were longer withdrawal times, if there was adequate preparation of the bowel. The females were doing better, and then also a specialized GI pathology group. And that means that it's not just the endoscopist that is able to have a high sessile serrated lesion detection rate, but also the pathologist, because the pathologist has to make sure he makes a proper diagnosis for us to show our sessile serrated lesion detection rate. And these are some examples of on the left side, the hyperplastic polyps, which quite remarkably always has the serrated epithelium on top, as you can see here. But on the right side, you see the same time of crypts in sessile serrated lesions. But what is more clear here is that the crypts are usually dilated on top. Which also means that when using MBI, they have like dark pits inside of open crypts, but they also have anchor-shaped crypts on the bottom. And sometimes those are also referred to as the elephant feet, so wide open crypts, which I think you can see are very different here from the ones that are here, where they are very sharp on the bottom end. You will understand, however, that if the pathologist just receives a very bad specimen for us, or maybe even only a superficial biopsy or a very tangential assessment, it will be very difficult for a histopathologist to give us the proper diagnosis, because, for example, the difference between hyperplastic and sessile serrated lesions is not so easy. So how about the gold standard for histopathology? Well, we know that if we ask an expert pathologist to reassess lesions, quite often they classify hyperplastic polyps as sessile serrated lesions. Look, up to 85% of cases. And we also know that in pathology laboratories, there's a high variability in the diagnosis of SSLs. And what we have shown is that if we implement e-learning systems amongst the different pathology labs, they help to increase consistent practice, which doesn't mean they all do the proper thing, but that's because it's difficult to have a gold standard. But at least you can see in the different labs, they are assessing such polyps in the same way, which is, of course, really the start for us. So why is it important to have high detection rates? Well, I think it's clear, because I've shown you, we know now that those lesions can also develop into cancer. But how about post-colonoscopy cancers? So the cancers that we detect, that are detected because of clinical symptoms, even though a recent colonoscopy was performed. And we know that about 1 to 9%, so still wide ranges, but that has to do with the quality of the endoscopy. But still there is a quite significant percentage of cancers developing in such way. So after a colonoscopy was performed. And the clear indication is here that those interval cancers, those post-colonoscopy cancers, are related to serrated polyps. And that's mainly because they're more often SIMP high, which means that they are of the hypermethylated type. And besides that, there are also macrosatellite unstable, which might be because they arise from this pathway, but also, of course, because this is the instability pathway that causes cancers in patients with Lynch syndrome, also known to develop relatively quickly and sometimes as a sporadic type. But that makes that we think that if we would do better in detecting serrated polyps during endoscopy, maybe we can lower the post-colonoscopy cancer rate. So those polyps can develop into cancer. It's an important cause of post-colonoscopy colorectal cancers, and that means that we have to detect all those sessile serrated lesions, the traditional serrated adenomas, and also the large hyperplastic polyps, especially on the right side of the colon. And they should be detected as well as resected completely. So how can we improve our detection rate during colonoscopy? Well, we have to be aware that we need to look for those lesions, that they indeed have a significant risk of developing into cancers, which I hope I've demonstrated to you now. But we also have to know what those polyps look like. So what do we look for during colonoscopy? And to define that, we developed the WASP classification. You must be aware with the NICE classifications for, on one side, the NICE 1 type polyps, which are the hyperplastic polyps, and on the other side, the adenomas, the type 2 polyps, which depends on when you use MBI, on the color of the polyp, the vessels, and also the surface pattern. We know that sessile serrated lesions can be in both groups. So after you've done your optical diagnosis for discriminating between those two, you should specifically look for typical characteristic of sessile serrated lesions to make sure you make a diagnosis and to understand what they look like. And if you have at least two of the specific 4 features of sessile serrated lesions, you should be able to make this optical diagnosis. And this is an example of a polyp that has all 4 characteristics. It has a clouded surface, which I always explain as the Dutch clouds, which are usually like the bulky clouds. You can see, I think, clearly here. It has an indistinct fake border, which is very different from adenomas. You can see some border here, but here it becomes more difficult to really delineate the polyp, which is quite typical for SSLs. It has an irregular shape, not nice, only sessile, but it is often bulky with irregularity. And it also has the dark spots inside the crypts, as I've shown you in the histopathology side, which are the open crypts. And I think you can see many dark spots in this picture. And this indeed is then a sessile serrated lesion. This is still the old wording that we used in the publication in Gut. So we trained endoscopists, 10 of them, using those criteria and tried to improve their optical diagnosis for serrated, sessile serrated lesions. And as you can see here in this slide, indeed, before and after training, there was a significant improvement in their accuracy for optical diagnosis. And actually this was a sustainable effect that also was measured after 6 months. So 6 months later, they were tested again for their optical diagnosis for those lesions. So those sessile serrated lesions with dysplasia, I told you, we have to really make sure we diagnose those well. And I think you will see here that's very easy to overlook the serrated part for this small adenomatous area, because it looks like a very small adenoma, tiny adenoma that you can can remove quickly by cold snare. But when looked at more closely, you can already see here that there might be like a mucoid cap a little bit and some vague blood vessels here. You have the feeling there's a cap over it. And when you look to with MBI, you can indeed see the clouds and also the dark spots within the crypts. So this is indeed a dysplastic area within a larger sessile serrated lesion. It was lifted with blue, with methylene blue, and then it becomes even more clear. And as I've told you, this is indeed an example of a small dysplastic area. This is a larger one that I think is a nice example of a dysplastic SSL. This part is really the sessile serrated lesion part, but within it, there's an adenomatous part here, and it was taken out by the traditional hot snare piecemeal EMR technique. And this is another one from a publication from the group of Michael Burke from Australia. So this is an example of a video, I think, where I can nicely show you the detection of sessile serrated lesions, because these lesions are, as you can see here, very, very flat in this patient. This is one SSL, and I think you could have seen it because of it looks like it almost has some cap, some superficial attached mucus there. But that indeed is a sessile serrated lesion that was very flat and irregular without clear borders. So those were two characteristics out of the four. This one has one more characteristic because I think you can appreciate the dark crypts within the polyp. Here is another one. Again, it looks like almost there's a very light shade on the mucosa, and with MBI, it becomes a bit better visible. This is clearly a patient with more than just one SSL, and that's very often when you detect one, you really should be aware that there can be more. And for all those lesions, the WASP classification was used, as you can see on the left side. Now we see a lesion that is suspicious for adenomatous change. So you can see on the right side the dysplastic focus, but on the left side, and also with extension on the upper hand of the serrated tissue as well. So this was a dysplastic SSL. Another SSL here, as you can see. Impressive one, very flat, but on the lower end at 6 o'clock, there's some more elevation in the lesion. And in the next example, you will see that the mucoid cap, so the attached mucus and some slight features, this is another one, but might also help you to detect the polyps, because you can clean them, but sometimes it becomes very difficult after cleaning them to really see where the polyp is. And this is what we do here. So just to show you that all the attached mucus and features can be cleaned. But look, then it is almost invisible, this polyp here. So you wonder, did I really see something, or was this just mucus? However, when you then turn on the MBI, you will still see it, because then it becomes clear there is indeed a different pit pattern in that area. And this is indeed, in this patient with sessile serrated polyposis, a polyp. The non-dysplastic precursor lesion on the side, but in the middle, there's an invasive cancer diagnosed in this patient with a large sessile serrated lesion that you can see here. So I think this was an impressive patient. We get those more often referred, an interesting one. We took a biopsy, and this was indeed, this part was sessile serrated lesion without dysplasia, whereas on the other side, that indeed was an invasive cancer. So how about polyp resection? Of course, it should be radical and it should be safe as always. For the sessile serrated lesions, if they're small, of course, like in any other polyp, like adenomas, the cold snare resection technique is the most easy one and also very radical. However, to resect those lesions, it's really important to delineate the lesion very well before doing so. And we know from the CARE study from Heiko Pohl, published already in 2013, that even though we think we take out polyps radically, even up to 10% of all lesions is still not radically removed when taking biopsies from the side of the resection area. However, as you can see in the lower end of this slide, this is really mostly due to the sessile serrated lesions. In 31% of the cases, these were not taken out radically. And I think you see two nice examples of lesions that were not taken out radically, because here's the scar, but here is still some SSL left, and the same here with the scar, and here SSLs, but also here left inside you. And it's very logical because they are not easy to delineate. So that's really what we have to do very well before we resect the polyp. NBI can help us a little bit here, but especially the use of submucosal dye injection will help you tremendously when putting in some methylene blue or some indigo carmine, like was done here. And you might still be aware there's a little part here left that should be taken out as well. So for the larger SSLs, we also like very much now to do cold snaring with piecemeal. And here you can see some examples. This is a cold snare piecemeal EMR of a larger SSL, and you can see the very nice sharp rims that you can achieve by doing so. And this is an example why I love to do this technique. It's easy and quick. And this is a patient where a proximal lesion was already taken out by cold snare piecemeal EMR. And here you can see another example of a cold snare piecemeal EMR in this case. So as the lesion was not so easy to delineate, and if doing so piecemeal, there's two advantages of lifting it with a submucosal dye. Of course, it facilitates resection, but also it makes the rims, the rims of the polyp, the demarcation, much easier, as you can see here. So now the dedicated cold snare is taken. You can see that here, and piece by piece, this polyp, by pressing the tip of the snare into the mucosa, you can see that this polyp will be resected. There is a small disadvantage, of course. You have to be radical, so you have to do it on all sides with a normal rim of mucosa. But when using the cold snare, of course, there is the chance of doing the piecemeal resection in one piece, so actually a single piece EMR en bloc is smaller because your snare is smaller. So you will be doing more piecemeal EMR instead of trying to catch the whole lesion into your snare at first. However, I think that nicely balances against the advantages of the velocity and the radicality that can be achieved by doing this technique. But most of all, the technique is very safe. And I will show you some slides to show you. So this was the literature up until recently, 3 studies that performed larger cold snare polypectomies. As you can see here, different sizes, very small studies, but showing a technical success rate, which was very good, with low rates of post-procedural bleedings, no perforations, but some recurrences. And that, of course, might be the result of piecemeal resection, like is the result of any piecemeal resection, as you know from literature. There was a very recent study by the group of Michael Burke, done by a former fellow of ours, Dr. Van Hattem. And what he has done is he has compared a prospective cohort of piecemeal cold snare EMR for SSLs with a retrospective cohort of EMRs done in the traditional way. So there is indeed a difference in timing, as you can see here. This was, of course, a more recent cohort. You can see here average size about 25 millimeters. Otherwise, no special things to look at. But here you can see the results. The advantage was that there was low post-polypectomy bleeding rates, no perforations, no adverse events in the cold snare polypectomies. And you can see there was indeed some recurrences. There was not recurrences yet, but what there was some, the en bloc resections were more often performed in the EMR, as I said, which is a little downside of performing piecemeal EMR. The resection times were comparable. So I think this technique is technically equally efficacious. However, it has the big advantage of a low risk of bleeding and other complications. Just one slide on surveillance for SSLs, just to show you that indeed patients with SSLs need surveillance. This is the recent guideline published last year in endoscopy, stating that patients with one SSL with dysplasia or larger than 10 millimeters should have surveillance endoscopy at 3 years. Then just some slides on the serrated polyposis syndrome. As I told you, when you detect one polyp, which is an SSL on the right side of the colon, you really have to be aware there might be more. And some patients fulfill the criteria for sessile serrated polyposis, so serrated polyposis syndrome. And recently the guideline, the criteria were updated. Those patients can either have 5 serrated polyps proximal to the rectum, all larger than 5 millimeters, but 2 must be even larger, like larger than 10 millimeters. Or, and then number 3, at least 20 serrated polyps. So serrated polyps can be either SSLs, but also TSAs and hyperplastic polyps, but they should be spread throughout the colon and not just be in the rectum, because we know we have quite a few of those patients. They don't have sessile serrated polyposis syndrome. So they should have also proximal lesions. The gray one is a one that was in the previous criteria, and those are the patients with family members with serrated polyposis syndrome, and they also have at least one polyp, but that one was taken out of the criteria. So it's just 1 and 3 now. Is it frequent? Yes, it's a frequent syndrome. If you look at the data we know from, for example, from the screening programs, we know that if you count subsequent endoscopies and you count all the polyps detected in the subsequent endoscopies, we know that in populations the prevalence must be somewhere between 0.4 and 0.8%. And that makes it the most frequent type of polyposis, even more frequent than the well-known familial adenomatous polyposis. However, as discussed before, the diagnosis depends on the endoscopists. The etiology of this syndrome is still unclear. Many patients have first-degree family members with colorectal cancers, but also many of those smoke, especially those with the multiple small serrated polyps. There's also patients that have multiple serrated polyps but not yet fulfill the criteria, but they still seem to be at an increased risk, which makes it not just clearly a definition, it's still a clinical definition, because we also don't have a germline cause for this disease. There is the germline RNF43 mutation in patients, usually with many family members with serrated polyposis, but this appears to be a very infrequent cause of the syndrome. And that makes us wonder whether it's really one syndrome or just a phenotype. However, it is important to make the diagnosis because those patients have really an increased risk for colorectal cancer, which might be as high as 70%. Most of the cancers are diagnosed at the time of or before the diagnosis of serrated polyposis. So many patients are sent to us with their cancer, and when we look at them, they appear to also have many serrated lesions and thus have the serrated polyposis syndrome. Of course, it's then important to make that proper diagnosis because we also have to give the proper treatment. And it might be necessary to either resect all the other serrated polyps or perform a larger resection than clearly necessary for the cancer only. So for the optimal care of serrated polyposis syndrome, it's really important for the time they diagnose with the cancer, but also for surveillance strategies afterwards to weigh the burden and the risks and the costs of regular colonoscopy surveillance against the prevention of the high risk of cancer in those patients. And I won't go, because of time constraints, into more detail about this syndrome, but I would be happy to answer any questions on that. So my take-home messages for you for today on sessile serrated lesions are that the serrated polyps are precursors for cancer and should be detected. SSLs with dysplasia are really advanced lesions, probably very closely on the way to develop into cancer, and they need to be radically resected, which means that you have to make a proper diagnosis and should be aware that you might only see the dysplastic area of the polyp, leaving the serrated tissue around it inside you, which is of course at high risk for the patient. Delineation of those lesions is important, and cold piecemeal EMR is the most appropriate technique for that. Surveillance is indicated for SSLs if large and or dysplastic. If one of those sessile serrated lesion is detected, there is often more, and it's also important to make sure you diagnose a patient with serrated polyposis syndrome appropriately, and also perform therapy and surveillance for those patients with this high-risk syndrome. I thank you very much for your attention. I'm happy to answer any questions.